Hello, I am Martin Lederman, co-founder of the organization One World, One Vision. Over a decade ago, my associate and I, while on a surgical mission to Belize, founded One World, One Vision in order to train local ophthalmologists and, by doing this, extend our reach. We were successful, and since then, our organization has gone to multiple countries and have demonstrated the success of our ideas. We added anesthesiologists and pediatric intensivists to the mission in order to train local physicians and make the surgical experience of our patients safer. Since then, we have realized that the paradigm of one patient, one student, and one surgeon, while successful, could not begin to address the need. There are tens of millions of children and adults with strabismus and amblyopia. We decided, therefore, to support and to promote a video course in strabismus and amblyopia and approached Dr. Burton Kushner to develop a curriculum and to recruit worldwide experts to give lectures. We stipulated that the course should be translated into multiple languages and to be distributed without cost around the world to eye surgeons. We are particularly grateful to our former patients and friends who have given the financial support to make our dream a reality. We are delighted that Dr. Kushner has accepted the challenge, and we hope you find the lectures both stimulating and educational, and that you share them with your colleagues and your students. And so, without further ado, I give you Dr. Burton Kushner.
Welcome, viewers, to this lecture on exotropia as part of the One World, One Vision comprehensive course on strabismus. I am Burton Kushner, and although I usually just moderate these lectures, for today's lecture I will be doing the presentation. If you are a first-time viewer to this lecture series, I want to thank you for tuning in. If you're a repeat viewer, I hope that means that you've been finding these lectures helpful. And welcome to you also. Exodeviations. They certainly seem simple at first glance. They're certainly not. And I find them one of the most interesting and challenging strabismus conditions that we deal with. Let's start with the classification of exodeviations, and in general, this parallels classification of all strabismus deviations. An exophoria is a deviation that, by definition, is never manifest. It's only latent. Then there's an intermittent exotropia. That's a patient who is sometimes straight and intermittently has a manifest deviation. And then there's a constant exotropia, which could be a congenital constant exotropia, a decompensated intermittent exotropia, or a secondary or consecutive exotropia. And we'll talk about these different entities separately. The bulk of this talk, however, is going to be about intermittent exotropia, as that's what's the most complicated and I think the most interesting. So let's start with an exophoria. By definition, it's always latent. If it's asymptomatic and it's small, you can perhaps not treat it at all. But they can be symptomatic, and the symptoms usually take the form of asthenopia, perhaps related to the patient cranking in accommodative effort to control the deviation. They can be treated with prisms, they can be treated with exercises, but in my experience, surgery is rarely, if never, needed for an exophoria. Now, a congenital exotropia is usually constant. It's often a large angle, and you can think of this as being very much like a congenital or infantile esotropia, except that the eyes are deviated in the opposite direction. Sensorially, it's like infantile esotropia in that there's subnormal fusion, there's alternate suppression, it's often associated with DVD. Now, an important thing for you to note is that congenital constant exotropia is a soft sign for neurologic or developmental issues. And you should at least consider a neurologic or developmental workup when you see a child with this. Do I always get that? No. If a child seems to be thriving and is attaining normal milestones, and if they're under the care of a good pediatrician or primary care provider in whom I have confidence, I merely alert that primary care doctor to be on the lookout for developmental or neurologic issues. And if anything shows up, they should intervene with an evaluation. Treatment is usually surgical, and the timetable for surgery is similar to infantile esotropia. And the sensorial results are about the same, subnormal fusion. Constant adult exotropia, as stated, can be a decompensated intermittent exotropia, or it can be idiopathic. And what's important to note is that if these patients are overcorrected surgically, they will be diplopic. If it's a decompensated intermittent exotropia, they typically have suppression of the deviating eye. They're typically not diplopic. And they may have what von Norden has described as panoramic viewing. It's as though they can simultaneously see out of both eyes at the same time, yet know which eye is looking straight ahead. He anecdotally described a patient of his who was a postal carrier with a constant exotropia. And the patient said that he could drive down the road using his dominant eye to look at the road and his deviating eye to scan the addresses on the side of the road. He actually had surgery which successfully corrected the exotropia, but he missed this panoramic viewing that he experienced preoperatively. Metaphorically, if we go to the arts, the idea of exotropia being associated with a wide view goes very far back. On your left is a Byzantine mosaic from the 5th century showing a common depiction of Christ as having an exotropia, metaphorically representing this wide panoramic view. In the middle is something from the Renaissance period, and even in modern movies, on your right, you'll see the actor who was chosen to play the lead role in Jesus Christ Superstar has a very marked, noticeable exotropia. So that's sort of a scientific correlate of this artistic, if you will, representation of exotropia having a panoramic viewing. It's as though the patients can see around corners, and they may miss this after surgery. Many artists are reported to have an exotropia. On your left is a self-portrait of Rembrandt. It's an etching. And Margaret Livingstone, who looked into this, observed that in 36 self-portraits that Rembrandt did, he was obviously exotropic in 35 of them. Notably, it was the right eye that was deviated in 23 of the 24 paintings, and the left eye in all 12 of his etchings. And thus he had no stereopsis or 3D vision. Many famous artists were strabismic. Dürer was shown to be exotropic in 4 of 13 of his self-portraits. And all of these artists on your right, Klimt, Chagall, Hopper, 2 Wyeths, and possibly Picasso were strabismic. Livingstone suggested that perhaps the lack of stereopsis or 3D vision enhanced the ability to create visual art. Something to think about. So let's move on to constant adult exotropia. As I said, it could be secondary trauma. Blind eyes tend to drift exotropic, and they can be treated with either recess resects or lateral rectus recessions. Obviously, if there's an amblyopic or an amaurotic eye, you'd want to confine surgery to that eye. These patients may be diplopic if overcorrected. And what's important to note is that amblyopia, even dense amblyopia, does not preclude diplopia. Some of the most bitterly diplopic patients I've seen were ones who had vision far poorer than 2200 in their deviating eye. Diplopia is a function of the fovea of the fixing eye and the periphery of the non-fixing eye. So even if the macular, foveal macular area has poor acuity, poor resolution, it's the periphery that determines if there will be a perception of a diplopic image. Consecutive exotropia, that's by definition, and esotropia, that goes exotropic, and it can be spontaneous or after esotropia surgery. And the treatment depends on what was done before. If they've had prior surgery, you want to pay attention to whether there is a limitation of rotation now, and you must address the limitation. If generous medial rectus recessions had been done, you may consider advancing them. If they were modest, you could consider operating the unoperated muscles. And I will say there will be a lot more in-depth discussion of this reoperation strategy in a separate lecture in this series on reoperations. So let's now move to intermittent exotropia. And for me, studying this entity has really been a 40-year plus journey. I love this quote from Dante, "Therefore, for your sake, follow me. I will be your guide." But when I think about intermittent exotropia, I wonder if this quote from Karen Russell isn't more appropriate. Nobody can ever get to hell without assistance. Hopefully we'll avoid that. So what's the history of my journey with this? Well, in 1970, I was a first-year resident, and I learned Burian's famous classification of intermittent exotropia from the 1950s. He broke them into 4 categories. If the patient has a bigger deviation at distance than near, he calls it a divergence excess. If it's the same at distance and near, he called it a basic, for lack of a better term. If the near is greater than the distance, it's a convergence insufficiency. And he observed that some patients appear to have a divergence excess, but they're just masking a bigger deviation at near. And if you can bring it out, and we'll talk about how to do that, he called that a pseudo divergence excess. Some people say simulated divergence excess. And he brought this out with monocular occlusion of 45 minutes to an hour. And according to Burian, the classification determined the treatment. Subsequent to the 1950s, this classification, even though I think it's flawed, was concretized. It was just set in stone. And now, really 70 years later, people are still using it or citing it. And I should just say parenthetically, when I say the distance is greater than near or the near is greater than distance, by definition, that's 10 prism diopters difference for the cutoff, for the classification. One of the fathers of psychoanalysis, Carl Jung, used to say that our children live out our unfulfilled fantasies. And this is a photograph of my daughter's first vehicle and the bumper sticker she wrote around showing. So as they say, the apple doesn't fall far from the tree. I questioned a lot about Burian's classification back as a first-year resident. And these ideas that I'm going to present evolved. In Greek mythology, it's said that Athena, the goddess of wisdom, sprang fully formed from Zeus's head. And I take this to be a metaphor for an hypothesis fully formed at conception. These ideas were not that. Think more of Sisyphus. They were built brick by brick with stops and backsliding. But that journey got me to where my thinking is today. Let's talk a little bit about the entity of intermittent exotropia before we talk about the classification of it. When a patient presents, you need to determine 2 different things. How good is their control, as seen on your left? And the control tells if you should treat the patient. Good control, you don't have to treat. Poor control, treat. The angle determines, once you've decided you need to treat, how much or what kind of treatment the patient needs. Because you see, some patients may have a large angle with good control, and you don't need to treat them. Some have a small angle and poor control, and they may be symptomatic and may need treatment. So I think it's important for you to develop an objective control score. And there are a lot out there, and I don't think it's as important which control score you use as much as you use one you're familiar with that's consistent to how you interpret it. In other words, if you say a patient's control today is fair and it was good last time, you're using an objective control score, you know what that difference represents. Now, I personally use a two-phase control score. I assign two numbers for each patient. I assign one number for how easily they break control and a different one for how quickly they recover, because they don't always go hand in hand. Some patients break easily but recover quickly. Some are hard to break down, but once broken down, their recovery is poor. So I like to make note of both. It's not crucial that you do that, but I think it's important that you have some objective system for grading control. Intermittent exotropia, sensorially, when they're tropic, they suppress the deviating eye. And classically, it's described as hemitemporal retinal suppression of the deviating eye. In 1984, John Pratt Johnson and Geraldine Tillotson presented a study suggesting that there is complete suppression of the deviating eye, but the trigger mechanism for causing the suppression to kick in is based on the hemitemporal retina. But suffice it to say, whichever it is, these patients are not diplopic because of suppression. And interestingly, when they're fusing, they can be sensorially normal to all of our usual tests, 40 seconds of stereopsis. I'll add that some patients that are said to have intermittent exotropia may be monofixators with a microtropia. And technically, if they have a manifest, even a microtropia, you can't call them or shouldn't call them an intermittent exotropia. But the literature is confused on this because many articles on intermittent exotropia don't separate out these patients. And the reason they don't is it can be very difficult to observe 2 or 3 prism diopter exotropia in a very young child. So be aware of that difference. And when you're reading a paper, pay attention to whether they're including these patients or not, because their outcomes can be somewhat different. With intermittent exotropia, as far as symptoms, often there's none. They may be asthenopic, just as I said with phorias, that may be due to accommodative effort to control the eye. They can be diplopic, and that's more likely to be in dim illumination. And many of them exhibit a symptom that's been named photalgia, which is kind of a discomfort in light, and they close one eye in sunlight. The old literature used to say they closed an eye to avoid diplopia. We know that's not the case because many of them continue to do that even after surgical alignment that is successful. Now, when a patient presents with an intermittent exotropia at a very young age, and I'll say that's approximately under 3 years of age, it's been reported that there's a high incidence of postoperative monofixation if surgery is done let's say under 3 years of age. And what's not clear and what's hard to flesh out is this due to the fact that if you get an initial overcorrection, which we like to get with intermittent exotropia, in a very young child, even a matter of a couple of weeks of being esotropic after surgery for intermittent exotropia, they may lose bifoveal fusion and become monofixators. Or, on the other hand, is this high incidence of monofixation because of a pre-existing selection bias? Is it the patients with subnormal fusion that come in with poorer control at a young age? And if they have surgery, they continue to be monofixators after. Well, that's a hard thing to sort out. And in a given patient, as I said, it can be very hard to observe if they have that microtropia when they're appearing to be straight. So I like to temporize if I can. If I can keep them straight enough till they're over about 3 years of age, I like to do so. But often I can't. Sometimes their control is just poor. And if I have to operate on a patient that's that young, I take a few steps to avoid losing fusion after surgery. I avoid a long-standing esotropia postoperatively. So if I see that patient even at week 1, and if they're still esotropic, I will either put on prisms to make them bifoveal, I'll alternate occlude, or when it's available, I may put them on phospholipid iodide, which is actually very useful in that situation if the deviation is small. It's very important, especially if you're temporizing, to correct anisometropia. I think one of the most interesting articles I've read in strabismus is by Jampolsky in the 1978 New Orleans Academy Transactions called Unequal Vision Inputs in Strabismus. And he points out that unequal vision inputs to the two eyes, meaning uncorrected anisometropia as one cause, is very destabilizing. So if you're going to cut the plus or over minus a patient, do it equally. And if there's any significant astigmatism, correct it. This video is going to demonstrate the adverse effects of uncorrected anisometropia and also something about how you can tell fixation dominance in intermittent exotropia. I'll talk about it first. This patient is left eye dominant. And you'll see that when we cover his right eye, it deviates. When we uncover, he fuses by making a vergence. But if we cover his dominant right eye, it goes out. When we uncover, he makes a saccade to pick up fixation with that eye and then makes a vergence to fuse the other eye. Covering the right eye and a vergence to fuse, cover his dominant left eye, saccade, and then a vergence. Now, if we hold up minus lenses over both eyes, that stimulates accommodation. It allows him, -2, to completely control the deviation. No shift on cover. But if we put -2 over his fixing left eye, his dominant eye, he should be accommodating and fusing, but he can't control the right exotropia. He breaks down because of uncorrected anisometropia. So our indication for intervention with intermittent exotropia is classically described as if the deviation is present greater than 50% of the time. That can be a hard thing to determine. We have to often rely on parent or patient history. And there are some patients that may think it's worse if they see the eye go in and out many times a day, even if it's not out for a substantial period when it goes out. They may notice that more than if the eye goes out a little distance and stays there. So we have to have some things to help us in making a judgment. Use the control score, as I said. If control is worsening, that can be an indication for treatment. Or if there are symptoms, diplopia or asthenopia, that can be an indication for treatment. Now, if I have a new child with intermittent exotropia, a new patient presenting, my initial intervention, especially if they're young, is non-surgical management to try and improve their control. And this will be alternate patching, 3 or 4 hours a day, and it's for anti-suppression, not for amblyopia management. And the fixation pattern determines my rotation sequence. If they're free alternators, which is actually uncommon in my experience, I'll patch one eye one day, one eye the next, the other eye, back and forth. If there's a fixation preference, I may go 2 days over the dominant eye, 1 over the other. Strong fixation preference, 3 and 1. Of course, if they're amblyopic, I just patch the dominant eye. Invariably, this improves not only their control, but the angle also, and I'm not sure why that is. And then I slowly wean them off. I cut the patching in half, and then I may do it every other day. I wean them off patching, and sometimes this holds them for a long time, but often the problem recurs. If it recurs, I'll repeat the same intervention, but this time when I taper them, I will over minus them by 2 diopters and put 2 to 3 prism diopters base in each lens in their glasses. Now, I know there was a recent PEDIG study suggesting over minus for intermittent exotropia can cause myopia. I actually looked at my own patients and found that not to be the case. I don't know if it's because I only used 2 diopters of over minus. The PEDIG study used 3, and I make up for that 1 diopter I'm not over minusing by the 4 to 6 of base in prism total that I'm using. And if I have them in these glasses and they control, I will wean them out of over minus and prism by the end of their teenage years. Now, sometimes this only bides time, and it ultimately recurs, and you have to do surgery on these patients. But biding time, I think, is of benefit in intermittent exotropia, and sometimes it'll give you several years. And my long-term review of patients in whom I did this found that in some cases, it's actually curative. Now, if surgery is indicated, all patients with intermittent exotropia should have a 1-hour monocular patch test to find the maximum angle, maximum at both distance and near. And they need a measurement fixating on a far outdoor target. Take them to a window, have them look at a flagpole, a stop sign, or better yet, take them outdoors if that's convenient, given your clinic setup. And both tests need to be done, the patch test and the outdoor measurement, because different patients will increase their deviation with one test or the other, but not both. And you want to operate for the maximum angle that you find. Now, this slide on the right is just to depict that and I use the term outdoor sensitivity to describe the patient that increases their deviation when they look at an outdoor target. If you have to take them to a window, if you can't take them outdoors, the distance from the window is important. You'll see on the left, the eye is close to the window, and you'll see how many degrees of retina the window subtends when the eye or patient is close. When they're twice the distance, that same window subtends a much smaller arc on the retina. There's less retina receiving outdoor illumination. So you want to stand as close to the window as you can, still allowing room for you to get in front of the patient with your prism and cover test and get a measurement. So let's talk now about this simulated pseudo-divergence excess. And I want to talk about what I now call the Scobee phenomenon. I formerly called it tenacious proximal fusion. Here's a hypothetical patient, very common, 30 distance, ortho at near. Is this a divergence excess, according to Burian? Well, if you patch the patient for an hour, monocular patch, many times you then find the near deviation increases and approximates or equals the distance deviation. Richard Scobee described this in the early 1950s, and as credit to him, and because the mechanism is kind of confusing, I call it now the Scobee phenomenon. And the presence of the Scobee phenomenon foretells a better prognosis. These patients do better. They have this helpful mechanism to keep the eyes aligned. The distance near differences, as Burian described, as I said earlier, divergence excess, basic convergence insufficiency. The pseudo-divergence excess was originally diagnosed by patients that manifested the Scobee phenomenon, or tenacious proximal fusion, that increased with a patch test. But it was observed in the early 50s that +3 lenses at near may unmask a bigger deviation in many of these patients. And what's confusing is that +3 lenses and patching are not the same, although they both may diagnose the pseudo-divergence excess. And this is not explicitly graspable. I want to try and explain it. Near patch test and +3 lenses. One, the +3 lenses suspends accommodative convergence, and the other fusional convergence, two different types of convergence. So how can many, but not all patients have the same response to each? Let's look at this hypothetical patient. 30 distance, ortho at near. +3 lenses at near, the deviation increases to 30. Is this a high ACA ratio? Well, if you just look at the gradient method of testing, say I got 30 prism diopters by relaxing 3 diopters of accommodation, that's an ACA ratio of 10. High ACA ratio. But it's probably not. Why not? Well, we didn't first eliminate the Scobee phenomenon with the patch test. So if we take the same hypothetical patient, now we're looking on the right on the slide, on the screen, 30 prism diopters distance, ortho at near. If we patched them first, they would have increased to 30 at near. Then if we add +3 lenses, it may just increase, hypothetically, another 10 prism diopters. That's an ACA ratio of 3 1/3, and that's a normal ACA ratio. So this is what I call a pseudo high ACA ratio. So the important point I want to make is that ACA ratios in intermittent exotropia can be calculated in all the usual ways: gradient method, distance, near, heterophoria method, provided that any near measurement that goes into the calculation is made after the contaminating effect of TPF for the Scobee phenomenon is eliminated by a 1-hour patch test. That said, I want you to understand and beware of the rare patient that has a true high ACA ratio. I'm often asked, patient 30 distance, ortho near, are they going to be esotropic at near if I operate for the distance? And the answer is in most cases, they're not, except here. So what are the characteristics? How do you find the high ACA ratio? And I've probably only seen no more than 20 to 30 of these in my entire career. They start off with the distance. We're looking on the left. The distance exotropy is greater than near. It does not increase with a patch because it's not that way because of the Scobee phenomenon. It does increase with a patch, with +3 lenses after the patch, because they have a high ACA. We've done the ACA testing the right way after a patch, and we've relaxed 3 diopters of accommodation. If you do a distance gradient ACA, -1, -2 at distance, you'll see they invariably have a high ACA. And a real tip-off is if you measure them very close, closer than we usually do. Just do a cover test at about 3 inches or, very, very close. You'll see an esophoria, where most patients were in closer than their near point of convergence and they break and go exo. Now, why is it important to recognize this patient? In my experience, 100% of them will have an esotropia at near if you successfully correct the distance deviation with surgery. And it's 100% sensitivity and specificity. Every patient that I've operated on that had an esotropia at near after surgery met these criteria. So how do I treat them? Well, high ACA, you get a lot of bang for your buck. A small amount of minus lens controls a big deviation, but they will need a bifocal while they're over minus. My experience, since I recognize how to treat them, is that everyone that I've treated normalizes their ACA ratio by the end of teenage years. And then you can operate on them in the usual manner, and they do fine. What about prism adaptation for bringing out the near deviation? Well, classic prism adaptation, where the patient goes home wearing a prism, has not rigorously been studied by me or anyone else to my knowledge. But I did look into the role of what I call a rapid prism adaptation. 30 distance ortho near, I sit them down with a trial frame, put 15 base in each lens, have them just read a paragraph, quickly do a cover test, and qualitatively, that will show me which patients are masking a big deviation at near. But quantitatively, it's different than the patch test. And I think this is worthy of a prospective study. We talked about flaws with Burian's classification. What are the new underlying principles that I think we should rely on? Well, I think divergence excess is probably not really an excess of divergence. It's probably an exotropia with an excess of some kind of near convergence, be it fusional, accommodative, or something else. And the new principles show, and Steve Archer beautifully demonstrated this in the article cited on the bottom of the screen, that there are myths about selective surgery. It's a myth that lateral rectus recessions affect distance more than near. It's a myth that medial rectus resections affect near greater than distance, and a myth that an R&R gives the same effect at distance and near. In almost all cases, you get what you need with respect to distance near differences. So let's look at how I think in 2023 or beyond, we should view this. Let's first look at the patient that starts with a distance deviation greater than near, as seen at the top. If you look at the row in white, if after the patch, that's your augmented near measurement, it's still greater at distance than near. Next column, Burian would call that a divergence excess. New classification says it's probably an exotropia with an excess of some kind of convergence at near. And the new surgical recommendations are you can do lateral recessions, or you can probably do an R&R. That hasn't been rigorously studied, but that is consistent with the understanding of this way of looking at distance near differences. Now, what if distance greater than near, if after a patch, they're equal distance and near? Burian calls it a simulated divergence excess. New classification says exotropia with the Scobee phenomenon. Surgical recommendations, your choice. You got a helpful mechanism going on. You could do laterals, you could do a recess resect, whatever your bias is. +3s at near. The exotropia at distance is still greater than near. The near didn't increase. Burian calls it a divergence excess. New classification, exotropia with probable near convergence excess. Same surgical recommendations as in the first row. Lateral recessions are probably recess resect. And with +3s at near, the exotropia is now equal at distance and near. Burian would call that a simulated divergence excess. This may be a pseudo or a true, rare, possible, but true high ACA. And more testing like we just previously described would be needed, and the treatment would depend on the results of that testing. What about the patient that comes in with the so-called basic, the distance equals the near? Well, typically we don't do an augmented near measurement on those patients, so the first column is not applicable. Burian calls it basic. New classification calls it an exotropia without the Scobee phenomenon. So it doesn't have that helpful mechanism. New recommendations are you can do a recess resect, or if your bias is for lateral rectus recessions, that works as well, but you have to enhance your formula, adding about 1.5 millimeters or 2 per muscle to get the same effect as with an R&R. Convergence insufficiency, the near exos bigger than the distance, well, it turns out that if you really study these patients, there are two different kind of patients that both meet the definition of convergence insufficiency. And I think it's important to think of them differently because there are different things going on. On your left, it talks about a fusional convergence insufficiency. These are patients that have a trivial distance phoria, they're usually not tropic, a bit or near phoria, probably not tropic, but just a bigger phoria, and they have low convergence amplitudes, but it's not on the slide, normal accommodative amplitudes. They do well with exercises. Contrast that with what I call an accommodative convergence insufficiency. These are the patients not with a phoria, with a convergence insufficiency pattern tropia. They have a small intermittent exotropia at distance, somewhat larger at near, but it is an intermittent exotropia. They typically have normal accommodative amplitudes, but if you rigorously test their ACA with gradient method and whatever, you'll find they have a very low ACA, sometimes zero. And that's why if you understand that, it's easy to understand why surgical options can be so difficult. If they don't have accommodative convergence, nothing will really equalize the distance near difference. So I've treated them with medial resections targeting the distance, lateral recessions targeting the distance, or recess-resect, and then relying on optical means to control the residual near deviation. More recently, I came upon what I call the Buckley procedure. Ed Buckley described this, where you can do whichever form of surgery you want, but transpose muscles, either move the medials up or the laterals down, to induce a V pattern. And doing that will typically create about roughly 8 prism diopters of V, and that helps these patients decrease the exotropia near in the down gaze reading position. So for the patient with a convergence insufficiency, distance exotropia is less than the near exotropia. These patients, if you look on the first row after a patch, they're still having a convergence insufficiency pattern. We would both classifications would call it a convergence insufficiency, and I just talked about the new surgical recommendations. R&Rs, lateral recession, medial resection, targeting the distance, and or add the Buckley procedure. But there were some patients where after a patch test, the distance deviation increases, and then distance equals near. The new classification, Burian calls that convergence insufficiency. The new classification would call that a pseudo-convergence insufficiency. And if that's present, you have your choice as to surgical procedures. I want to spend a minute talking about exotropia with lateral concomitants, and I'll mention that this is also covered briefly in the lecture on reoperations, but it's relevant in both places. So Sally Moore, a great orthoptist from New York, in 1969 observed that if an intermittent exotropia shows a decrease in the deviation in both right and left gaze, in this hypothetical construct, 30 in the distance, 15 in both right and left, there's a high incidence of overcorrection in primary after surgery. Now let's just look at this pattern. What can cause a 30 prism diopter deviation to decrease in both right and left gaze? And I'll just add parenthetically, the early articles either had a 10 prism diopter decrease as the cutoff in right and left gaze, or a 50% cutoff, and both have been used by different authorities. What can cause this? Well, if both lateral rectus muscles were weak, I have an exotropia, and if I look to the side, this abducting eye doesn't move as well because the lateral is weak, the right eye catches up to it, that would cause a drop. But if the patient has a de novo exotropia, it's hard to fathom that they have weak lateral rectus muscles. The other thing that causes this is if they have overacting medials. I'm exotropic. When I look to the side, this medial pulls this eye in more, decreases the deviation. So that must be what causes this in the de novo situation. But what about when it happens after prior lateral rectus recessions? It's not uncommon. You weaken the laterals, the deviation comes back. Because you weaken the laterals, they now are less in right and left gaze. In this situation, the laterals are iatrogenically weakened. So this is a different mechanism than the de novo lateral concomitants. And these patients are not prone to overcorrection in primary. However, because the deviation is smaller in right and left gaze, they may be overcorrected in side gaze if you don't tailor your surgery accordingly. Surgical goal. With my younger intermittent exotropes, I like them to be between 5 to 15 prism diopters overcorrected, esotropic on day one. Unlike most others, I do not overcorrect adults. In my hands, they just don't straighten the way children do. And I aim for orthophoria, just bordering on diplopia. I typically do symmetric surgery. I like it if they're diplopia-free in primary and just a little bit right and left. They're diplopic because they're getting on the esotropic side. That's my endpoint in adults. So in summary, we've talked about when to operate, conservative management, importance of surgical measurements after a patch, distance outdoor measurement, talked about distance near differences, discussed the two different types of convergence insufficiency, talked about high ACA, and overcorrecting younger patients 5 to 15 prism diopters. So I want to thank you for your attention. My wish for you is that all the roads you travel will lead to orthophoria. If you enjoyed this lecture and found it useful, I hope that you will tune in to the other lectures in this One World, One Vision comprehensive course on strabismus.
In bringing you this video course, there are many thank yous. Thank you for viewing the video course on strabismus. We hope you found it stimulating and educational, and that you share its insight with others. We at One World, One Vision extend our heartfelt thanks to the lecturers who shared their years of study to make the video course worthwhile. And of course, to Burton Kushner for taking on the burden, happily we hope, of development and moderating. We also thank the Board of Directors for their continued guidance. We thank our donors for their financial support that made this video course possible. An enormous thank you to the video team of Sweet Sadie for their extraordinary efforts to make the course both visually and auditorially extraordinary, and for their technical guidance of the lecturers. Thank you, Rachel, Tim, Eddie, and Bill. If you are interested in learning more about what we do, go to our website, www.oneworldonevision.org. And finally, if you have comments or thoughts or ideas, you can email me at owov2020@gmail.com. Goodbye.